Hello. Am I audible?
Yes, welcome,
Dr.
Abha.
Neeru, you can introduce Dr. Abha. Yeah.
It's my proud privilege to introduce Dr. Abha Majumdar, ma'am. She's our mentor. She's Director, Center of IVF and Human Reproduction at Gangaram Hospital, New Delhi. President Medal for Best Medical Graduate of the year 1970 to 75. Excellence Award Obs and Gynae by Hippocrate Foundation. Abdul Kalam Gold Medal 2015. Rashtriya Gaurav Gold Medal Award. Distinguished Teacher of Excellence Award by National Board of Education, awarded as IVF Champion of the 2019 Icon of IVF of North India, and Best Integrated National Team IVF by Economic Times of India. Lifetime Achievement Award by IFS, Indian Fertility Society, Course Director for Postdoctoral Fellowship in Reproductive Medicine, Member of Editorial Board of IVF Worldwide, Peer Viewer for Journal of Human Reproductive Science, Member of Advisory Board for Journal of Fertility Science, Field of interest we all know in fertility, ART, reproductive endocrinology, endoscopy. So welcome, ma'am. Everything is less for you. So we all are fan and waiting for you, eager to listen from you.
Dr. Neeru, I think Dr. Abha has to be made a panelist. Whoever is helping us from backend team, please make Dr. Abha a panelist so that she can unmute herself and share.
I have been
Already done.
unmute.
Okay.
Just done it in one.
Welcome, ma'am. Welcome, ma'am.
Thank
Welcome,
you.
ma'am.
Thank you
Welcome.
so much.
Ma'am, we have introduced you. So
Yeah,
now
yeah.
you
I
can,
heard that. I could hear it, but I couldn't speak.
okay,
Yes.
ma'am. So you can start sharing, ma'am.
Oh, I have to speak now.
Yes,
Yeah,
ma'am.
yeah. You can start
Okay,
sharing.
then can you stop sharing my
Vani, stop sharing. Yeah, yeah. Ma'am, just a minute.
Bhavani's lecture is over?
Yes,
Yes,
ma'am.
ma'am. Yes, ma'am.
Oh, okay.
Yeah, yeah. It was a nice talk.
All set for you, ma'am.
All right, thank you. So further to Bhavani's talk, I'm going to talk on what's new in the management of adolescent PCOS. I hope everything works. Can you see my slide?
Yes, ma'am.
Yes,
Visit.
ma'am. Yeah, yeah.
So when we say adolescents, who is adolescent? It is girls between 10 and 19 years of age. In this age group, body image, sexual identity, peer interaction are critical for the evolving personality. Apart from association with medical disorders and irregular menstruation, features of hyperandrogenism in adolescents can have a very substantial impact on self-esteem and can cause psychosocial morbidity. They don't like to meet friends, they don't like to meet family. They have a lot of psychological setbacks, especially with the androgenic symptoms. Timely diagnosis and medical intervention may prevent health sequelae and contribute to psychological well-being. Now, this whole lecture which I'm going to give, I have taken um, I've taken the help of a of the International Evidence-Based Guideline for Assessment and Management of Polycystic Ovarian Syndrome 2023. And this has the views of Monash University, ASRM, Endocrine Society, ESHRI, CRE, PCOS, and the European Society of Endocrinology. So many people have given us the gist for this, and that is how I am going to present this to you. I have changed over from slideshow only to get the name of all the societies. So when we have a PCOS girl and we need to manage her, what do we as health professional need to know? We have to learn to be very truthful, give correct information and education on PCOS at all levels of health professional training to address knowledge gaps. And I will tell you what are the knowledge gaps. We tell PCOS girls, you take this treatment, you will become all right in 6 months or 3 months. or 1 year. No, this is not there. PCOS is a genetically imprinted condition on us, and hence it is not possible to say you will become all right. It is like wearing spectacles. If we say wear spectacles for 6 months, your eyes will become all right. That's a wrong statement. Similarly, we need to give them correct information, and it should be tailored. It should be provided to all PCOS girls in a very respectful and empathic manner. Now, when we say tailored information, we do individualized embryo transfer, we do individualized controlled ovarian stimulation. Similarly, this information should be tailored to what that patient needs to know about her PCOS status in a very empathic manner. The diversity of the population should be considered when adapting practice paradigms. Now, I mean, whether she's a vegetarian, she's a non-vegetarian, whether they allow her to sort of go out and exercise, or you have to devise some method for her that she should be able to do some physical activity on a daily basis. Girls should be also counseled on the risk of misinformation and guided to evidence-based resources. Having said that, common presentation in PCOS adolescents which require management. So menstrual symptoms, you all agree that there could be delayed menses, there could be prolonged bleeding, there could be non-cyclical early or late bleeding. So this is the commonest presentation about menstrual symptoms. Then come the hyperandrogenic symptoms. Out of that, the most troublesome or the most high nuisance value symptoms are hirsutism, acne, and baldness. Baldness is generally frontal and very typical of PCOS girls. And there are weight issues. And these girls say their counterpart eats a little bit and they eat a little bit, but they gain more weight and the counterpart doesn't gain weight. With this comes psychological symptoms with a negative impact on body image. They start feeling negative about the body from their peers. And last of all is we have to initiate longitudinal monitoring for early identification of comorbidities of PCOS. What are the comorbidities of PCOS? Diabetes, hypertension, hyperlipidemia, risk of cardiovascular accidents, and endometrial cancer later in life. So these are the 5 comorbidities which we always have to see from adolescents, and I'll tell you how you monitor all this. So management spheres, they are all interlinked. Like lifestyle management and weight issues could also address the menstrual symptoms and the hyperandrogenic symptoms, and altogether the psychological issues also. But I'm trying to separate and give you a little bit of information on all these managements separately. When we talk about lifestyle management and effectiveness of lifestyle interventions, then it is the core focus in PCOS. And please do not start with that you have to reduce weight. Weight is not our issue. It is bringing in some type of activity in girls who have been, especially young girls, who have been diagnosed with PCOS. If you hit upon weight, come back to you. So there are benefits to healthy lifestyle even in the absence of weight loss. Why? Because metabolic health is always of concern, whether it is a lean PCOS or an obese or an overweight PCOS. So exercise alone or diet along with exercise and behavioral changes should be recommended. So all you do in diet, just don't tell her that stop eating, just tell her 3, 4 things which she can stop eating. Maybe all the C's, like, the chow mein, the chips, and the chocolate. So maybe we can start with the 3 C's. Just take them out of your diet, eat early evening food, don't eat after that if possible, and exercise a little. Go and play a game, swim, play badminton, cycle, or something. These girls would be much happier if we tell them to do a purposeful exercise rather than something which is very, sort of tedious. And this will not only reduce their weight marginally, or maybe not reduce, but it will definitely improve metabolic health, which is central adiposity and lipid profile. And it will also maintain and prevent weight gain, and it may lead to modest weight loss. So please don't tell these girls that you have to lose a lot of weight, because they will run away. They will never be able to do it. One step at a time, and it helps them a lot. those girls who are not overweight in the adolescent age group, the focus should be on healthy lifestyle and prevention of weight gain. Healthy lifestyle is only two things: adding a small little exercise to your daily routine, removing 2 or 3 junk things which they generally are fond of, especially adolescents, and eating a diet which finishes at night by 7:30 or 8 o'clock. Then we have menstrual symptoms. What are the most important menstrual? One is delayed menses, 2 mahina, 3 mahina periods. Prolonged bleeding. Once I start bleeding, I don't stop. And one is non-cyclical early or late bleeding. What are the main methods to treat this? One is oral contraceptive pills, metformin, progestogens, and inositols. Having said that, I'll devote one slide to all these. Combined oral contraceptive pills. Now, these have the most important role in adolescence. Please remember, when I'm talking about combined oral contraceptive pills, I'm talking about the normal oral contraceptive pills, not the cyproterone acetate or drospirenone containing ones. So they should be used only after clear diagnosis of PCOS to treat hirsutism and or irregular menstrual cycles. So I'm sure Bhavani must have told you how do we diagnose, and we need both the symptoms, irregular periods and hirsutism, to diagnose PCOS in adolescents. And first 3 years, the periods could be irregular. So we do not diagnose them to have PCOS. We always say they are at risk of PCOS. And once a diagnosis is made, we can start using combined oral contraceptive pills. Then please, there is no advantage of using high dose ethinyl estradiol. So don't look at the progestogen, which is there in the pill. Look at the ethinyl estradiol, because this is the one which we want to minimize in PCOS girls because of their tendency towards metabolic syndrome. So all oral contraceptive pills which has ethinyl estradiol less than 30 microgram is much more desired in these girls rather than those which have more than 30 micrograms. The 35 microgram ethinyl estradiol is always associated with cyproterone acetate preparations and should be considered as second line therapy over other COCPs, because we need to balance benefit of this oral combined pill to the adverse effect, which would include venous thromboembolic risk, metabolic risk profile, side effects, cost, and availability. Because we are not talking about 1 year of oral contraceptives. We are maybe talking about 20 years of oral contraceptive, 10 years of oral contraceptive. And hence we have to see in the long term, how are these contraceptives going to affect the metabolic risk profile of these young girls later in life. Now, PCOS-specific features such as obesity and cardiovascular risk factors need to be considered when we are prescribing combined oral contraceptive pills. So if the girl is already obese, she has history that her father had stent, her mother has hypertension. So already it is a family which has metabolic syndrome and is at risk for cardiovascular diseases. If this is so and you are going to prescribe a long-term pill, let it be a low ethinyl estradiol pill. Then we come to metformin, the so-called wonder drug. In between, metformin had lost its importance, and now again it has regained a lot of importance, especially in young PCOS adolescents. So one thing I would want to tell you, that before giving metformin, if you can motivate the girl to an active lifestyle, they have similar efficacy. The metformin is not superior to an active lifestyle intervention. You can do away with metformin if you can introduce active lifestyle intervention for her. Metformin does lead to mild adverse GI side effects and is generally dose dependent and self-limiting. So you have to start for a lot of girls with a lower dose. These are young girls, and if you give them something which will induce a lot of acidity and nausea and distension and loose stools, she will stop the medicine immediately. So you start with 50 milligram and do the increment weekly or bi-weekly. And extended release preparations may minimize side effects, improve adherence to the medicine. Maximum daily dose is 2 grams in adolescents. So giving a 500 milligram tablet is giving her a medicine in a homeopathic dose, which is not going to affect her as you want in the metabolic profile. So However, 2 gram maybe is for a adolescent who is also overweight or obese. We can reduce the dose to 1.5 gram, but it is now considered safe for long-term use. However, indications for ongoing requirement needs to be considered. We need to see we give it for 1 year, 2 year, 4 years, how long. Then comes long-term use may be associated with low vitamin B12 levels. So you always remember someone who's on long-term use of vitamin B12, especially if they are vegans. Vegetarians are generally there who are not vegans. They may not have so much of vitamin B12 deficiency, but you find it quite a bit in our population who's not on metformin also. And then where there is exposure that, this girl, 18-year-old, might become a diabetic early because she's overweight and her family has a lot of history. Here, we must look at B12 levels and replace it wherever we find it deficient. Then we come to a very important combination is we give combined oral contraceptive pill with metformin. Where do you use it? So combined oral contraceptive is better than metformin for management of hirsutism with irregular menstrual cycles. But metformin is better than combined oral contraceptives for metabolic indications in PCOS. So if there is mainly hirsutism and irregular menstrual cycles, contraceptive pills are better. But if there are metabolic indications like obesity and already her lipid profile is going high, or you find that, there's a very strong history of diabetes, then metformin is a good drug for such a girl. Now, we can give combination of both. It may be most beneficial in high metabolic risk group, including those with a BMI of more than 30 kg per meter square. And I'm sure most of you must have seen adolescent almost reaching this stage of BMI with maybe impaired glucose tolerance or high risk ethnic groups and hirsutism and irregular cycles. What are the high risk ethnic groups in our country? It is mainly the community which does, I would say, which is business person, mainly Agarwals, Guptas, some Pandits also. Maybe the lifestyle and the genetic profile is such that this becomes a high risk ethnic group. The Kashmiris have very little chances of metabolic profile being disturbed. So it is different ethnic groups which are more prone to develop metabolic risk. Now, where oral contraceptives are contraindicated or they are not accepted, so many mothers and grandmothers would say, okay, you give it for 2-3 months. I don't want my daughter to be on a long-term oral contraceptive, or it is not tolerated. The moment you give it, the girl starts vomiting. There, metformin may be considered for irregular menstruation and hirsutism, but it will have a lesser benefit. So what do you do? Progestogens. These come to our rescue after oral contraceptive pills and metformins have been considered. And they have a very, very important role in my clinical practice. I have sort of surrounded my whole clinical practice on just these three drugs. Progestogens are, what are they? They could be a progestogen like norethistedone or medroxyprogesterone acetate, or they could be natural progesterone, the micronized natural progesterone, which is available as oral, injectable, and vaginal or rectal administration. And there are progesterone-only contraceptive pills also, marketed by Organon. So there are two symptoms which you will encounter in your practice. One is irregular long cycles with normal menstrual bleeding. The girl says, I don't get my periods for 45 days, 2 months, 2.5 months. Then I get a normal bleeding for 4-5 days. Another one is irregular long cycles that they don't get 45, 50 days periods. But when they get it, it is heavy menstrual bleeding. Both these groups need different method of management. The first group, what do? You say, okay, I've seen you, and you just need a progestogen for withdrawal bleeding every 20 to 30 days. Don't wait for 2 months for your periods to happen. The moment 20 to 30 days have passed, you will take this medicine for 5 days and you will get a withdrawal bleeding within 10 days of the last tablet. What are the two drugs which we use most commonly? Medroxyprogesterone acetate and norethistedone. The total dose is 100 milligram. So remember, it is 10 milligram BD for 5 days for either drug. And after the drug finishes, give them clear-cut instructions, wait for at least 10 days. If in 10, 11 days also there is no withdrawal bleeding, what do you think of? Either the endometrium was very thin when you gave her and she's not growing her endometrium after 30 days or maybe after 60 days also, or she's pregnant. So never rule out. I mean, always think of pregnancy also in these adolescent girls, which they could have at times unknowingly. Now, the second problem was irregular long cycles with prolonged or heavy menstrual bleeding. Here, they need slapping back of the endometrium, which is estrogen dominated. That is why they go on bleeding for a long time. So, what do you use? I like to use a progestogen. However, in the US, they like to use micronized natural progesterone or progesterone only pill also. This is, you have to use continuous and cyclically. So you use it for 21 days or 25 days and stop it, let the bleeding happen, restart on day 2, day 3, or when heavy bleeding is there, even day 1, and again give it for the same duration, again restart it, and there will be a time when the patient or the girl will say, oh, I have very normal bleeding on day 1, 2, 3. I started on day 3, and then when I leave it, the bleeding is like quite normal. I use 3, 4 pads a day. That is the time when you know that you can probably now put her on a oral contraceptive pill. And suppose you have given progestogen for 3 months and yet her bleeding does not become normal and she's still bleeding very heavily. So what do? Then you introduce an ultrasound. You look at the endometrial thickness. You rule out a submucous fibroid or polyp in the uterine cavity. Or you may also need to do a local examination, even if it is under anesthesia, it is right, to rule out a cervical reason for bleeding. And I have had a patient once, which I published many years ago in our Foxy journal. She had a small fibroid at the cervix, which used to go on bleeding, and I was fed up of giving her progestogens. Nothing helped her. And then we did a UA, found this small little fibroid jutting out in the cervix and removed it. No ultrasound could see this fibroid because it was almost, outside the cervix. Now, what is the role of ultrasound if you look in a bleeding phase of a girl? If it any time you can see her day 4 till day 12, if bleeding is continuing, whenever you put the ultrasound, I mean, maybe it is day 12, and you put an ultrasound probe over her abdomen, and you find that her endometrium is more than 5 millimeter. It is 6, 7, 8, 9, 10, whatever. The best way to bring her endometrium down to normal is give her progestogen or natural micronized progesterone to revert or prevent endometrial hyperplasia. Give it cyclically, like I told you earlier, and you can give it for multiple cycles also. Now, if you find at that time it is less than 5 millimeter, means 4, 3, or 2, here also the history is there that she bleeds normally, then you can start medroxyprogesterone acetate withdrawal any day between day 21 to 35, 10 milligrams BD for 5 days. Our aim is that she should get about 8 periods in a year. So you can always tell her that, you can wait for 35 days. If your periods don't start on their own, you start medroxyprogesterone acetate for 5 days, and in another 7 days, you will get her period. So ideally, it becomes 45 days, one cycle she gets, and she can continue this. If she wants more cycles a year, she can start a little earlier, start from day 30 or day 25 or day 21. Or oral contraceptive pills are very good for these girls for 21 days. So the endometrium is normal. They don't bleed unlessly, and you put an ultrasound and it is 4 mm or less. Then you give them a withdrawal with medroxyprogesterone, or you put them on low dose oral contraceptive pills for 21 days. Beware of only one thing. Endometrial hyperplasia occurs by prolonged unopposed estrogenic stimulation of endometrium. Untreated estrogen excess in PCOS without progesterone exposure is associated with increased risk of endometrial cancer. Don't be surprised of getting this. Generally, in adolescence, it's not common, but in 20s, I've seen multiple cases where the family was averse in giving hormones or OCPs to the girl, developed developed endometrial cancer in her 20s only, at 26, 27, 28, because she always had delayed periods and went on bleeding and then again had delayed periods. Anyways, I would not leave the last drug here, inositol, which is a lot, which is a favorite drug for a lot of my colleagues. However, I have never used it in my life. So I found a lot of literature on this in this PCOS guideline 2023, and they wrote inositol given on individual preferences of probably the gynecologist and the patient, because it has limited harm and it has potential for improvement in metabolic measures, yet with very limited clinical benefits on ovulation, hirsutism, or weight. So it has very little clinical benefit on all this, but yes, metabolic measures, it might help. Then two is metformin is to be considered over inositol for hirsutism and central adiposity, though metformin has more GI side effects than inositol. Women taking inositol and other complementary or nutritional therapies. So in this review, they have considered inositol as a nutritional therapy or a complementary therapy, must inform their health professionals about it. And they have not described the specific types of inositol, the doses or combinations of inositol, because they feel that there is lack of quality evidence, and hence they have not been able to tell us what doses and in what combinations inositol should be used. So we come to the next part, management of hirsutism. And you see, there is a lot of overlap. I made a chain picture. It is all interlinked. Hirsutism management goes along with menstrual management, and we try to reduce the number of drugs given to these girls. So hirsutism, if you see pharmacological interventions, number one is combined oral contraceptive pills. And the best is a low dose. But then if you feel that metabolic risk is not very high, then maybe we can go for oral contraceptives, which have anti-androgenic progestogen. So anti-androgens are there, topical therapy is there, and then cosmetic measure and direct hair removal, you all know about it. I will come to combined oral contraceptive pills. And here, this script has been taken from ACOG Committee Opinion 2019, where they say treatment of acne and hirsutism should not be withheld during ongoing longitudinal evaluation for at-risk PCOS. So the girl is at-risk PCOS, but she's come with a lot of hirsutism and acne. So you should start treating that. And here they say that hormonal therapy should not be started before menarche. So once menarche comes in, then only hormonal therapy to be started. But the revised PCOS guidelines say that it should be started once the diagnosis is made, and which is if the diagnosis is made, say, within 3 years of menarche, after 3 years of menarche. However, if response is suboptimal after 6 months of hormonal therapy, and when they say hormonal therapy, it could be spironolactone also, additional hair removing therapies or anti-androgens can be added. So here they say add anti-androgens or hair removal therapies only if response is sort of suboptimal. For moderate to severe hirsutism, hormonal therapy and anti-androgens can be started concomitantly. So when they say hormonal therapy and anti-androgens, then they mean that anti-androgen containing OC pills or OC pills with an anti-androgen like spironolactone. Any estrogen containing therapy should be more effective at reducing acne, particularly for adolescents with premenstrual acne flare-up. So it is estrogen which reduces the acne, and it is the anti-androgen which reduces the hirsutism. Anti-androgens are used to treat hirsutism in the presence of other effective form of contraception. So if you are using anti-androgens not as OC pills, but as the medicine itself, then you need to use some type of contraception, even in adolescents, where they would never admit to having a sexual exposure, but it is then maybe best to give it as OC pills. So anti-androgens usage is based on recommendations. Spironolactone is given in the doses of 25 to 100 milligram a day, has lower risk of adverse effects. Cyproterone acetate and drospirenone used as OCPs in my country. Cyproterone acetate is available alone also in some countries. Finasteride has an increased risk of liver toxicity. Dose is 5 milligram a day. Increased risk, but you rarely see it. Flutamide has a very high risk of severe liver toxicity, dose 250 to 750, and it is not used. So the first 4 drugs are used: spironolactone, CPA, drospirenone, and finasteride. These are the preparations. The only drospirenone containing low estradiol drug is Yaz. So see if Yaz is available locally, then it has ethynyl estradiol only 20 micrograms with drospirenone 3 milligrams. DHA, everywhere we have CPA 2 milligrams, and ethynyl estradiol is generally 35 micrograms. So I mean, if you don't want to use it as a combined OC pill, then in places it is available as 12.5 milligram or even 100 milligram, which is now not available. In the beginning, 100 milligram was available. Spironolactone is aldosterone antagonist, not taken as a OCP, can be used in combination with the OCP doses, 50 to 200 milligram daily. Side effects could be, it would still lead to irregular menses. So you will need to give something for irregular menses. And if there is a risk of that the girl could be exposed to a sexual assault or a sexual contact, then we need to give her a OCP also. I'm going to tell you about topical eflornithine. Flornithine. Now, this is FDA approved. It is 13.9% cream, irreversible inhibitor of ornithine decarboxylase, which is an enzyme essential for hair growth. It can be used as monotherapy for mild cases of facial hirsutism or as adjunct to other therapies if there is more. Effect is seen in 4 to 8 weeks. Reversal of hair growth within 8 weeks of discontinuation may happen. Doses twice, application at least 8 hours apart, and the trade name is Eflora Hinder Ellen Vaniqua. Now, the most important thing with topical eflornithine is that you can combine it with any of the drugs like drospirenone, CPA, because they act on the ovarian source, and this acts on the periphery. Mechanical laser light therapies for hair reduction. You all know so much about it. I don't need to tell you anything. But, just doing this reduces facial hirsutism, but it is very therapeutic for related depression, anxiety, and quality of life for a lot of girls. So just treating the facial hirsutism mechanically also. And we have to remember that PCOS girls need more treatment sessions compared to idiopathic hirsutism. And it is very important that wavelength and delivery of laser treatment varies by skin and hair color. Laser is relatively ineffective in women with blonde, gray, or white hair. So beware very fair girls, it would be less effective in your patients who are very light in color. Additional of combined oral contraceptive pill with or without anti-androgens to laser treatment may improve the overall look of the girl and maintain it for longer. Mechanical hair removal with intense pulse light should be considered, but the benefits are less, and we should not use home-based IPL kits. Having said that, management of hirsutism in a nutshell is multimodal therapy is most effective approach to the treatment of hirsutism. So just don't put them on one medicine and say, wait. While they are waiting, they can go for some type of local treatment, maybe laser, hair removal, waxing, something like that. And this includes lifestyle changes. So physical hair removal and androgen suppression or blockage, everything should be done. So you've done lifestyle changes, you physically removed the hair, androgen suppression is done with a medication that slows or prevents new hair growth. Hormonal therapy not to be started before menarche, but once you started, the effect will come in 6 months. So some type of local treatment is very important. Any estrogen-containing therapy should be effective at reducing acne, and OCPs particularly are effective for adolescents who report premenstrual acne flare-ups. So patients should be assessed at routine intervals every 3 to 6 months for adverse effects and response to treatment until they are stable, when they should be monitored annually. I normally tell my patients of hirsutism, take a selfie for all areas where you have excess hair. And then after 6 months, you can take another selfie and then compare the two. Monitoring of serum androgens is not recommended. You can only see the hirsutism, which is what they have. You may or may not grade them also, but it is important to know that yes, it has reduced visually. So last is psychological therapy, which Dr. Roma is going to tell us in detail. I only want to highlight two things, that adolescents with PCOS who have depression, anxiety, disordered eating, body image distress, low self-esteem, or psychosexual dysfunction should be offered cognitive behavior therapy wherever appropriate. Psychological therapy could be considered first line management, antidepressant medication second line, preferably mostly in adults. Lifestyle intervention and other therapies like oral contraceptive pills, metformin, laser hair removal, targeting PCOS symptoms are important because they also improve psychological symptoms, and not managing anxiety and depression may impact adherence to PCOS treatment and management. So please be tactful with these young girls because they are anxious, they are depressed. So you have to talk to them in a very positive way, not impose a lot of do's and don'ts on them. Then only they will adhere to your treatment. So ACOG recommendation for adolescents in 2019 is that hirsutism and acne should be taken seriously because of the effect on self-esteem and quality of life and potential for psychosocial morbidity. No clear consensus guidelines on diagnostic criteria for PCOS in adolescents within 2 years of menarche. Thus, gynecologists should exercise caution in assigning this diagnosis prematurely. Treatment of acne and hirsutism should not be withheld during the ongoing longitudinal evaluation for possible diagnosis and confirmation of PCOS. Finding of polycystic ovarian morphology on ultrasound has a prevalence in adolescent girls in almost 40%, and it is not predictive of presence of future development of PCOS. So please do not use ultrasound to see polycystic ovarian morphology in young adolescents. Pelvic ultrasonography is not routinely indicated unless serum androgen levels or the degree of virilization is so much that we are concerned for an hormonal ovarian tumor. Now, follow-up of PCOS diagnosed at an early age. This is how I follow up. I haven't found this anywhere. It is, I tell them to buy a weighing machine, take their weight once a week, keep it in the bathroom. And the moment the weight goes up by 1 to 2 kg, they should have an alarm ringing in their head and reduce this weight, because once the weight goes up by 10 kgs, it would be very difficult to reduce it. Ensure menses at least every 40 to 45 days. OGTT should be done yearly, not just fasting sugar or not just hemoglobin A1C. Blood pressure should be seen yearly for these young girls. Lipid profile should be done yearly. Having said that, adolescents have a long way to go, and wrong diagnosis or a very premature diagnosis of a disease which they are so afraid of socially, they hear horror stories of PCOS from their friends. They can make their path difficult. Thank you very much.
Thank you so much, ma'am. Or as always, a very nice deliberation. There were a few questions in the chat box by Dr. Manisha Jain. She wanted to know, as per the conventional teaching, we should give withdrawal for 10 days with progestogens, at least in long
Uh,
amenorrhea patients, especially
no,
in ovulatory.
no, it is only the dose should be sufficient of progesterone, and it is 100 milligram dose divided in 2 or 3 doses, whatever way you want to give. But you have to give adequate dose. If you give a lower dose, then you can go for 10 days. If you want to give 10 milligrams every day, then give it for 10 days and then wait for another 7 to 10 days. All right, Manisha?
And another question is, ma'am, from her only, that she wanted to know that there's some patient who routinely come for a say, pregnancy counseling, pregnancy counseling, and they incidentally find PCOS with a thick endometrium. Do they need a biopsy?
I think a biopsy is only needed if a thick endometrium doesn't shed completely. So the most important thing is to repeat your endometrial thickness on day 3 or 4 of menstruation. And if it is anything like 4 or 5 millimeter, they don't need a biopsy. A persistent endometrium after shedding If is more than 7 mm repeatedly, definitely needs a biopsy. This is the cutoff which we have read in all books.
And one more thing I want to you to tell everyone that how do you monitor patients on metformin? If you have started the young girls on metformin, how do you monitor them?
It is mainly, what I tell them is unless you do not start lifestyle interventions, metformin will not work. My example to them is in a swimming pool, if we start lot of waves from right to left and tell the girl to swim from left to right, she will face a lot of resistance. But if we can stop the waves, she will swim easily. So metformin only stops the waves. She will still have to swim to the other side. So she will have to have some type of exercise, good amount into her lifestyle for metformin to work best for her. So if she just keeps on taking a suboptimal dose of metformin for years also, the metabolic profile will not change, Niti, and it will not even help her in weight loss. But if she is exercising with metformin, she will lose weight faster and her metabolic profile will also change much faster.
Do we need to do any tests, ma'am, by the
No.
patient on
I
metformin?
don't do any test. It's just this that I look at her BMI, I look at her central obesity, and if she's got something more than just irregular menses and hirsutism, metabolic syndrome, if these girls have, they have acanthosis, there's a family history of diabetes, even if her blood pressure is normal. I mean, so many girls in adolescence who are very overweight, I find the blood pressure already mounting up. This
Yeah.
is good enough to say that metformin in a full dose, that is 2 gram daily, whether it is slow release or normal release, has to be given.
Thank you, ma'am. Thank you so much. It was wonderful to have you on board, as
Thank
always. And we have Dr. Ashok Kumar has also joined us. Sir is here. Dr. Ashok Kumar is the president of AOGD. We are honored to have him with us. Um, Bhavani. So Dr. Ashok Kumar is Director Professor and Head of the Department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Sciences and Ram Manohar Lohia Hospital. We all know him very well. And he's presently the president of AOGD. Sir, we would like you to say a few words.
Uh, Thank you. First of all, Dr. Vicky Saxena, our chairperson of AOGD, she is a very good ambassador of AOGD, organizing lot many webinars on infertility and reproductive outcome. And this series on PCOS is always a need of the hour. And AOGD is also thankful to Haryana chapter of IFS and IFS for organizing this webinar. uh, Dr. Pankaj Talwar, Dr. Shweta Mittal, and Dr. Mala Arora, and Dr. Seema Mittal. So thank you very much all having me here in your program. And always AUGD is interested in all academic activities, and we would like all of the participants to be updated about all the uh, diseases and disorders of our women, so that they can provide good services and good outcome to all of them. So thank you very much for having me here. I will not be disturbing you in between the webinar. So Dr. Vicky, please continue with your program. Thank you so much.
Thank you, sir, for the kind words. And now I invite Dr. Mala Arora, who is the mentor of our SIG and a guiding force behind us. Dr. Mala Arora, so just say a few words before we go ahead with the next talk.
Dr. Neeti, Dr. Mala will be joining at the end.
Okay,
She
I
is
thought
not
she's
in
here,
Mumbai.
so I just
She's
thought.
there, but she
Okay,
is muted because she's busy in some very important thing.
okay,
So at the end, ma'am can give the concluding remarks.
okay. Then we go ahead with the
Yeah.
next talk. We are looking forward to hear from Dr. Roma. So Dr. Roma Kumar is senior consultant psychologist, Sir Gangaram Hospital, and she's also founder of the Saksham Mental Health Clinic. And she's profoundly known for her work on adolescents. Also, she has a lot of publications on them. And now I invite her to speak on the social issues of these children who suffer from PCOS.
At the end. Thank you so much, Neeti, for the introduction. I'll just share my slide. And I think before I go on, I think Dr. Abha actually said a lot of stuff and she made such a good talk. I don't think I can do better than her. She's way too good on everything. So, of course, we've seen that, when a client comes to a psychologist is not for PCOS, certainly not for PCOS. And what they come for is various other areas of concern. So it's very difficult for a psychologist to start talking on PCOS immediately, but we pick up the symptoms and we start understanding what the problems the adolescent girl is going through. So we know that the adolescent is a holistic development where there's physical development, there's social development, and there's mental and emotional development also there. So all these three areas come into practice. Uh, and we know that adolescence is beyond the physical, and the PCOS is definitely going beyond the physical. Uh, Literature says that patients with PCOS have significant difficulties in their quality of life, and their scores are different from the ones, from the normal and the PCOS. So the diagnosis is most important, and it does have a very adverse impact on the quality of life, the emotional and social fitness. And most of the clients who come to the psychologist are mainly the adolescent is either going through anxiety or depression, or usually having an academic issue. So from there, we pick up most of the symptoms that the adolescent girl may be having. So what people actually think of PCOS is that being overweight or there's infertility. And whereas we see PCOS actually is having as hormonal weight gain, chronic fatigue, anxiety or mood swings. Uh, of course, we've spoken of the hirsutism, there's excessive hair and acne. There's a lot of difficulty in falling asleep and also sustaining the sleep pattern. There is hair loss, and we know that there's irregular periods also, which the earlier speakers have already spoken about. So the PCOS iceberg, let's understand what that is, what is there which is visible and what is not there that is just completely invisible. The invisible part is the anxiety. Now, anxiety starts interfering with a lot of other areas of daily life. And the first area that the parent sees is the child not doing well academically, because the child is unable to concentrate well or is unable to perform and is having difficulty in sustaining a lot of friendships also. And adolescence, we know, is a period where we have a lot of infatuations, we have relationships, and we are growing with our self-esteem, our self-concept, our self-worth areas. So when the client comes into us, is either coming in because there's the feeling of isolation, feeling of depression, low self-esteem and confidence, and body image issues. There's a lot which has been talked about, brain fog these days, and there's poor interpersonal relationships, decreased appetite is a problem. There's a decreased sleep pattern is there. So all of these interfere, and that's why this is a hidden area. And very often when they have been referred to the psychologist, they come pretty late. So when they come very late, it gets tough to begin talking on the lifestyle changes or working on the anxiety and the depression area. The invisible part again is the low libido. We know that during this period, they are partying, they're clubbing, they're doing a lot of deal making on the Instagram, and they don't want to show themselves. They're quite overwhelmed with certain situations, especially in the peer interactions. Daytime fatigue is very often seen, so they are not concentrating in the classrooms. They are usually, when in a holiday mood, they are sleeping at a different hour. They are waking up hours are in the nocturnal time. Uh, Cravings and hunger are seen. I've seen clients where parents are reporting that she's all the time trying to eat and there's emotional eating happening. So that's another very big area of concern. Uh, Insomnia, sleep apnea happening. Uh, they are wired, but they're pretty tired. So that's the area that the psychologist actually works on, and works not only on the adolescent girl with the PCOS, but also works on the family, and also tries to understand that what exactly out of this whole thing is affecting them. And usually in history taking, they do not talk about the PCOS. It's only when we start talking about various lifestyle areas or their obesity or their hirsutism or acne, that's when it's an off mark that the parent will say, yeah, we had gone to the gynecologist. So for them, they're not talking about this area much. So left to the psychologists, we have to work on the area which is coming in more for like the anxiety or ghabrahat ho rahi hai, they start talking on that, or they're very sad. So those are the areas that we start working on. The body image battles. PCOS changes their bodies. We are well aware of that, which makes the adolescent girl feel very different from the other adolescents. They start feeling that they are not good looking. They start feeling that they will not be able to attract a lot of people. While with psychologists, we see that, they have started interacting on the social media platforms to the to groups on various areas. And also another area which is of concern because of the body image battles is the body cutting, which is happening very often. The second area is suicidal ideation is growing very high in adolescent girls with PCOS. So there's higher levels of body dissatisfaction which is coming up, and this needs to be really worked on. Uh, Many adolescents also report feeling that hirsutism actually taken away their, female identity. They talk of going to the parlor very often, or they are shaving their bodies, or many of them going to for laser treatments, and they feel that why them, why me, why am I affected by it? So somebody needs to listen to their issues more than just focusing on the body weight. And the physical changes actually erodes the self-esteem, and the anxiety and depression is very often seen. Some of it is hidden because a lot of people feel that people who are in the overweight, or the girls who are overweight, they're happy people. They make you laugh. They're fun to be with. But what's happening within them or within inside them, nobody actually understands. So when a adolescent girl comes for talking about these areas, it's important to address these areas so that, she doesn't feel very alien, or she's in, of course, sync with a lot of feminine ideas. Socially, because while in their growing years, they're going through this, they may face bullying, of course, isolation, and conform to unrealistic beauty standards. A lot of them spend a lot of money on cosmetic products, and leading to a lot of more inadequacies within themselves. We've heard from our ma'am also about the menstruation, that menstrual irregularities can be of significant distress. Fear of potential infertility weighs heavy on adolescent girls. A lot of families, the mothers start talking about, if you have this kind of weight, you'll never satisfy anyone, or you're going to have fertility issues. So this keeps weighing on the child's mind, and further, this is going to lead to inadequacy, feelings of inadequacy and anxiety. And this uncertainty surrounding the reproduction can lead to persistent sense of worry, leading to a lot of stressful behavior. The emotional burden, the adolescents with PCOS are at a higher risk of, we know that anxiety and depression. And a lot of studies find that young women with PCOS have significant higher levels of depression and anxiety, and they have no one to talk to. Back at home, when we talk to the families, most of them are talking or focusing only on the weight or on her eating patterns. They're not focusing on what is it that is happening inside her. So emotional area, I always say that, in our culture, we don't talk about emotions. We don't allow our girls to talk about emotions. We're not allowing them to vent out what's happening to them. What is this doing to them? So rather than putting just a diagnosis, I think working holistically with the psychologist is most important, and also psychoeducating the family around the same topic. So uncertainty around PCOS is there's variable symptoms. All of them do not fall in the same symptomatology. The diagnosis is complex, and anxieties about their future fertility, long-term health complications, ongoing management of symptoms. So there's non-compliance quite often. The girl may have gone to the doctor, the girl has been given the recommendations for medication, and yet she's non-compliant because the family is probably non-compliant, or she's hearing from others that why should you be on these pills. And of course, coping and mental well-being. So there's uncertainty around a lot of these areas. The social domain, the fear of being judged or misunderstood is quite common, and that can make it difficult to confide in peers or creating a sense of loneliness and isolation. Bullying is another area. I've already spoken about it at length, and some families may not fully understand the condition, leading to misunderstandings and a lack of emotional familial support. So, very often, these girls would come and tell us that back at home, I have no support. So she wants to come and see the psychologist more often. Whereas the family will tell the child, why do you need to go to the psychologist? You don't need the psychologist. You're unnecessarily spending money with the psychologist. The psychologist is only going to listen to you. We are there to help you. But on the other hand, there's so much dissonance in the same area. So the child gets further affected. Impact on the academic performance. That's where a lot of children come to us because of poor academic performance, and it can contribute to cognitive issues such as difficulty concentrating, impaired memory, chronic fatigue. Your energy levels are quite reduced, high levels of anxiety and depression. It affects your ability to focus, retain information, and perform well. And we are also aware that the menstrual pain can lead to frequent absenteeism from school or causing students to miss critical lessons and fall in their studies further. So what do we do about it? We're aware of this, but what do we do? So I think that's exactly what we are doing at this point, and I'm happy that all of you are connecting together and also working in a holistic manner. We need to reduce the stigma associated with PCOS, encourage an open dialogue, foster a more understanding and supporting environment, provide appropriate treatment, increasing the awareness, and managing symptoms better. We have spoken about a lot of these myths. I don't think I'm going to focus on this. The interventions are that psychological counseling and therapy. Most important is the cognitive behavior therapy that works the best in adolescents going through the PCOS syndrome. It promotes emotional health and also helps the child understand how to reach being mentally agile and having good resilience. Peer support groups are another area. Joining these support groups can help adolescents share their experiences, can reduce their feelings of isolation and provide emotional support. We know that the peer group can actually give a lot of support to each other. In fact, these days I have adolescent peer groups who are coming themselves for for a peer or for somebody who they are friends with, that she needs help. And I feel that we are going that one step further. So it's important to psychoeducate the young youth, the school population and the family, how to address these areas in a holistic manner. PCOS education programs, which are structured programs that help the individuals understanding what PCOS is all about, its symptoms, and the strategies that can empower them with the knowledge. I am again and again talking of how it's important to talk to the family. Educating family members about the PCOS can actually foster a supportive and empathetic home environment. So that is the most important. Holistic and comprehensive approach will incorporate psychosocial interventions alongside medical intervention. And I think it'll help mentally and emotionally, and also give support to the individual who's going through this kind of a area of concern. Thank you so much.
Thank you so much, Dr. Roma. It was a beautiful talk and on a lot of aspects which we were not aware of. So thank you so much. And it was great to have you around. So with this, we will come to the end of this session. Any questions? Dr. Picky, you want to make any comments or?
I think it is a very much neglected part that you have focused on today. And I think Dr. Ruma had a beautiful presentation, which really we are facing. And we should be having more sessions, having psychologists along with us. It has to be a multidisciplinary management of PCOS all across the life stage, not just adolescent, reproductive age group, perimenopausal. So I think you made a very important point, and we should all focus on this also. And we should have, in fact, some red flags where we need to refer to you. In case we find, sometimes these girls are very much under stress and distress. So what are those points? What are the points where we, like you said, the parents are saying, kuch nahi hai, don't worry about it. So what are those red flags? I'm sure parents and all of us are also very interested in the welfare of the child. So we need to refer to the psychologist. I think
Yeah,
it's
so from
Thank
there,
you.
from physiology, it becomes pathology.
yes.
So we
Yes.
should know that till what extent it is normal stress and where it becomes a distress and needs a management by a psychologist and psychiatrist if required.
And I
Thank you
think
so much,
the
Dr.
peer group thing that you said is very, very important because
Yeah,
they think parents don't know anything. But when the
yeah, of
parents
course.
talk about their experiences, it makes a lot of difference.
The
Yes.
friends are the most important, this thing for teenagers, all the teenagers.
Right.
The most important people are friends. So, yeah. Thank you so
Thank
much.
you.
And with
Thank
this,
you.
we come to
Thank
the
you.
end of the first session. Now, I invite Dr. Bhavani to go ahead with the second session. Dr. Bhavani.
So now we will begin with the second session. And first, we'll have the panel discussion. The moderators of the panel discussion are Dr. Neelam Bapna. Ma'am is the co-convener of this SIG, and she's consultant PGYN at Shivani Fertility and IVF Center in Saket Hospital, Jaipur. I would also like to welcome Dr. Parul Garg. Dr. Parul Garg is also a co-convener of this SIG, and she is head of Department of Reproductive Medicine at Artemis Hospital, Gurgaon. And I would invite the panelists. I would request the moderators to invite the panelists.
Okay. Hello, everyone. Can I have a slide for the CVs of the panelists?
Dr. Neeti, Dr. Mala has also joined. I see her there. So if we can take a minute to introduce ma'am.
Yeah. We were waiting for her.
Yes.
Bhavani, can you just show Dr. Mala's slide? Bhavani, can you share the screen and
Is my screen not visible?
no, Bhavani, we can't see. While you were reading the CVs of Dr. Neelam and Parul also.
Okay, I'll just a minute.
Yes.
So Dr. Mala Arora, we all know her very well, but just to introduce her, she has been chairperson of ICOG 2017, and then afterwards, before that, she has been on board of various organizations she has been heading. She was even vice president of FOXY in 2011, and presently we are honored to have her as mentor of our special interest group. And Dr. Mala Arora, we would like her to say a few words of wisdom, give us a few words of wisdom on adolescent PCOS. Dr.
Yeah.
Mala, ma'am.
Hello. Can you hear me?
Yes, ma'am.
Yes, ma'am.
You're audible.
Yeah. So
Bhavani, stop
I think this
sharing.
is a very, very important topic you have taken up for discussion. And I know presenting with PCOS, and as the lectures have highlighted, it is so important to deal with them empathetically, sympathetically, and counsel them properly. I think one thing I would advise all practitioners, because we are busy, we may not be able to counsel them well. It is important we take the help of a counselor and a dietitian.
Yeah.
Lifestyle modification can change a lot of things. You're already all aware. But the important thing is be optimistic when you talk to them. Don't tell them all the problems that PCOS can cause, because they're already on the verge of depression. These adolescents that are overweight and emotionally eating are already on the verge of feeling low. They need an optimistic approach. And I tell most of my patients, all you need to do is change your lifestyle and PCOS will go away. Don't worry, it is not something that will stay with you. So I think my only message is wonderful deliberations. I really enjoyed them all. And I'm looking forward to the panel discussion. And I'm sure you will spread this message across that we have to be more optimistic when we talk to adolescents. Thank you.
Thank you so much, ma'am. Thank you for your inspirational words. And with that, now we move on to the panel. Bhavani, can you start showing the CVs of the panelists so that the moderators can introduce them? Bhavani, you are muted. Bhavani, you are muted.
So, good evening all. So I would like to invite our panelist. Dr. P.K. Saxena. She's a director professor of Obs and Gynae in Lady Hardinge Medical College. She's a winner of 34 gold medals and editor of 10 books and published more than 250 articles. The chairperson of AOGD and currently she's an executive member of IFS.
Thank you. Thank you, Doctor.
Can we have the next slide, please?
Hello.
Dr. Leena Vadhva, she's a professor, HOD Medical College, Alwar. She is credited with setting up of first IVF center at ASI Hospital. She is currently a treasurer of our IFS. Dr. Ruma Satvik, she is a consultant at IVF consultant Sir Gangaram Hospital, and she has a various publications in international and national journal. Dr. Nitasha Gupta, she is a IVF consultant and a cosmetic gynecologist. She has received a gold medal in Fertivision and a R.D. Pandit National Award. I would also like to invite Dr. Neha Mishra. She's an assistant professor Obs and Gynae, RML Hospital, New Delhi. And she has received a Young Researcher Award and has various publications in international and national journals. Dr. Manishi Mittal, she is a senior consultant, Mittal Maternity and Nursing Home Center, Yamuna Nagar, and she's a secretary, Yamuna Nagar Obs and Gynae Society. Dr. Rita Bansiwal, she is a professor, Department of Obs and Gynae, Safdarjung Hospital. She received a KD Nair Best Clinical Repair Award, Paper Award, and also received an award for the highest tubal ligations done in a Population Week 2014 from Delhi. That's it. Okay. Welcome you all. So we start with the panel discussion. Let me share the slides. So as we do a daily practice, we encounter these adolescent PCOS, and so much of discussion has already been done. So we still have a dilemma in diagnosing the adolescent PCOS and when to treat them. Let's hope we can solve these queries through this panel discussion. So case one is the 16-year-old girl. This menstrual history is 5 to 6 days, occurring at every 60 to 80 days, that is irregular, since the age of menarche, that is 13 years. She has a history of hirsutism that has been increased over last 2 years, and she's been shaving every 2 to 3 days. There is also associated acne, and she has a family history. Her mother is diagnosed as a PCOS, and her mother brings her for further investigation as she is very anxious about her daughter may have PCOS. So on examination, BMI is 32, blood pressure is normal, and on physical examination, we found acne, hirsutism, and acanthosis nigricans. And there is no obvious Cushingoid features, and our physical examination otherwise is normal. On lab test, there's LH is 10, FSH is 6, HbA1c is 5.9%, and 17 hydroxyprogesterone, DHEAS, total testosterone, and TST, thyroid stimulating hormone, and the prolactin levels are normal. So other causes of hirsutism has been ruled out. So first question is in adolescent, at what point after onset of menarche do irregular cycles indicate ongoing menstrual dysfunction? Dr. Piki.
Dr. Parul, this is a very important question and it has already been answered in the previous lecture. But the latest PCOS guidelines 2023 clearly state that in the first year after menarche, you don't have to worry too much. But after 1 year and less than 3 years, if the child is having periods before 21 days or after 45 days, then that is thought to be abnormal. And after 3 years, like in this child, she had her menarche at 13 years and now she's 16. So beyond that also, if she's having less than 21 days or a period longer than 35 days, it is thought to be pathological. And the other thing is, if the girl is having primary amenorrhea by 15 years, till 15 years, or she has had her breast development and 3 years beyond that, if she does not menstruate, then that is also considered to be abnormal.
Yes, ma'am, this is rightly said. And irregular cycles and ovulatory dysfunctions are a normal component of this pubertal transition. So the defining this abnormality is very challenging.